Okay, great. Thank you so much. So thank you for the introduction, and I'm really happy to be here. I'm really going to share with you just a little bit of my thoughts and like my workings through what I'm hoping to be able to work on even much further. So just a little bit of a build up around integration of hypertension screening and treatment in Kenya. So I'll give a background. I'll talk a little bit about some efforts towards integration of HIV and hypertension. And and at the end, I will talk about differentiated service delivery, which is DSD, to support integration and what I'm planning to do next. So just as a background, I think we've talked a lot about this today. Cardiovascular disease is the #1 cause of death globally. We have big losses in terms of death of about 17, resulting in losses of about 17.9 million lives annually. And hypertension is really the leading risk factor for cardiovascular risk in sub-Saharan Africa. Hypertension is not itself a cardiovascular disease, but it can lead to hypertension-related heart disease. And hypertension really is largely undiagnosed. And if it's diagnosed, it's not under control. And that's really why there's a big concern around hypertension, especially in sub-Saharan Africa, where there's vertical systems for HIV and hypertension, where there is lack of medicines and human resources in terms of numbers and training. The figure on the right shows the global burden of disease, 2019, where hypertension, high systolic blood pressure was really the #1 top risk factor for cardiovascular diseases. So when you look at the background, you already know this. There are 38.4 million, or maybe you do or you don't, there are 38.4 million people who are living with HIV. And you can see here in East and Southern Africa, 20.6 million, and West and Central Africa, 50 million. So about 90% of a big number of people reside actually in sub-Saharan Africa out of the 38 million. When you compare on the other side hypertension affects about 1.28 billion adults, and 100 million, you can see from this, it's the number of people living with hypertension is about 100 million in sub-Saharan Africa. And hence this double burden of hypertension and HIV. If you look at the prevalence of hypertension in adults aged 30 to 79 years, it was about 39%. This was from data which was pooled analysis of hypertension of about 104 million participants, and it's the biggest study that we do have. And they looked at data from 1990 to 2019 on people 30 to 79 years old, and it's the same figure that you see on the right. So from here you do see that they are about globally, nearly a half of people remain undiagnosed, as well as approximately 40% are treated, and less than half of those who are treated actually achieving control. But the sad fact is for sub-Saharan Africa, only about 13% are achieving control, and you can see the color coding here. So when you look at the other side, so looking at the prevalence of both hypertension in people living with HIV, we have about 23.6%. This was a study by Bigna in 2020, which really tried to look at the combination of both hypertension and HIV, and it was a meta-analysis among people living with HIV. In those who are aged 50 and older, and because the population of people living with HIV is really aging, the global prevalence of hypertension was estimated to be about 42%, so really much higher. When this, I just wanted to show you for sub-Saharan Africa. I just picked for women because that's what you could get, and this is the same figure which I showed you in the other one, which is the world trends for hypertension. And you do see in sub-Saharan Africa, it comes second to Oceania, which is really, when you look at the number of people who are undiagnosed, is really huge. And then when you look at those who are treated but not controlled, and then those who are diagnosed and untreated, and then those who are controlled, So when you look at this spectrum, you see these changes in terms of both age, with obviously doing better for those who are older, but those who are younger, obviously not as well. But if you compare to Sub-Saharan Africa to other regions, you see that we still have a big gap in terms of diagnosis, treatment, and control. When you look at NCDs, hypertension is really the most common NCD globally. This is from the NCD Alliance report, and also you also find that about 72% of those with people living with HIV the prevalence of NCDs is, you find 72% actually did have hypertension. Is the most common, rather than in terms of when you look at among all NCDs. In terms of Kenya, the most frequent NCD is actually hypertension among people living with HIV. In a longitudinal study that was done a few years back, hypertension was still the most frequent NCD. So this is a study which we did in Kenya, in Kisumu, and the PI is Dr. Kerry Fakwa and Dr. Stephanie Page, and I was the site PI for this study. It was, we recruited about 300 HIV people living with HIV and 300 people who are not living with HIV. They were HIV negative. And we did look at metabolic syndrome, which goes beyond hypertension, but I only just picked hypertension. And what we did find is that overall, there were 33% of HIV negative and 18% of people living with HIV having hypertension. And of those, 47% had been previously diagnosed, and 37 had been on hypertensive during the last 2 weeks. In terms of then those who had the prevalence of hypertension, it was lower among those people living with HIV, which was not what we expected, but that's what we did find. But what was more important is really looking at this diagnosed and on treatment. You do see that really a big number first are not diagnosed, and then a big number are not treated. And this is really what motivated me to look at integration. So as part of my writing, I did write a K, and I was looking at the barriers to integration, and I was mapping using the social ecological model, looking at the various barriers. Because of implementation science, we do think the first thing is looking at what are the barriers to integration, and then what would be the proposed solutions. So there are several things, but I'll just highlight some. In terms of policies and guidelines at that time, there were none, but moving forward in the last few years, there have been more policies in country and also globally to really support integration of HIV and NCDs. Lack of data on implementations and costs, and common things that if you ask anybody, they don't have blood pressure machines, they are not trained on hypertension. There's issues around workload and self-efficacy for treatment for hypertension. And among the patients themselves, there's lack of knowledge around NCD care. There's lack of adherence support and the high cost of care, which is a big problem in Sub-Saharan Africa, where insurance maybe coverage is a bit lower. There are proposed solutions there, but I will not talk about them right now. So in terms of some of the strategies then that have been thought about, and this is reported in the NCD Alliance report around long, full and healthy lives for those who are living with HIV. One is around task shifting and task sharing. Two is around digitalizing and integrating health systems and capacities. Three is a big one around supply chain partnerships, so private partnership model and pooled procurements. And then four is differentiated service delivery. So I'll give examples from work which is ongoing. I started to look at task shifting. My first proposal was looking at task shifting, putting in treatment protocols, and then training staff around, and then supporting them through an audit and feedback where you look at data and you support them. That was my proposal. But in that period of time, then there are these studies which were also funded by NIH, which is the HLB Simple. And Chris, I know you recognize some of these. Obviously, it is you're part of the consortium. And one is Pulesa, Uganda, which is looking at task shifting, as well as TaskPen, which is also looking at task shifting in Zambia. And there's a MAPIT project, which is also in Nigeria. There are some also in Kenya through the AMPATH project. There's been a lot of work around task shifting and other individuals actually working around task shifting and task sharing. The second thing is around digitalization and integrating health systems. From the consortium, the HLB Simple Consortium, which NIH funded, there's one around the Scale Up SIRE, hypertension in Mozambique, which uses a systems thinking and a systems approach to improving hypertension screening and treatment. There is the IHAT in South Africa, which also looks at data and how to improve data systems to screen and to care for hypertension. And then in PATH, there's also a system around PATH supporting the Healthy Hearts Africa, which is funded through the Resolve to Save Lives, which is working on many things, but one of them is ensuring supply of medicines. But today I will talk about a little bit around differentiated service delivery. And so for those who are not familiar with differentiated service delivery, is now used a lot and widely in HIV. Is really a patient-centric approach, which is simplifies and adapts HIV services across the continuum to make sure that it actually meets their various individuals and their needs. And this was developed in 2016 in the WHO guidelines. And there's been a lot of work going on in the last few years around differentiated service delivery. And it has been shown to improve viral suppression, improve retention and follow-up among people living with HIV, and also decongests health facilities. So what do you do in differentiated service delivery? You really provide and tailor services by the type, the location, provider type, and frequency of visits, and the package of services. And you can see that a little bit more on the right. So when you talk about when is the frequency of your clinic and refill visits, and this is adapted for hypertension. So is it going to be every 2 months, every 3 months, every 6 months? Where is it? Are you going to do it in the hospital or in the community? Who is going to provide? Is it going to be a physician? Is it going to be a nurse? Is it going to be a pharmacist? And what is the package of service? So in Kenya, 44% of people living with HIV are on a DSD model, and 88% are in a facility-based model, which is mainly the fast track model, where you go to the, you spend less time going to the clinic, and then you just go to the pharmacy after you have for your regular drug pickups. There are also two other things to consider when you're doing differentiated service delivery, is either individual or a group-based model. So in an individual model, you are based at the health facility on the lower side here. It's based on a health facility or not based in a health facility. Where if it's based in a health facility, you just rapidly pass, like the fast track that I've talked about, and then you just go to pick up your medicines at any place in the facility designated for that. In the community, then you can pick it at a peer-led drop-in center, a community outreach point, a mobile outreach service. In the group model is the same thing, but now you are in a group and it offers some peer support. So it's a peer-led group or a healthcare-led, worker-led group. So what am I thinking about? So one of the things that I want to really explore this issue about DSD for integration, to really support what is already ongoing in work around integration. So the thing that I'm hoping to do in the next few months is to conduct a discrete choice experiment to inform the design of a DSD model. So a discrete choice experiment is a quantitative method where you want to know what characteristics of a differentiated service approach matters to those people living with HIV and hypertension here. And it can also be used for hypertension alone and others. How much does it matter, and what are the options of differentiated service delivery they would prefer to have, so that we could tailor it to meet their needs? And so the two aims are, one, to assess the perspectives of people living with HIV to identify their characteristics, and then two is to actually assess their preferred DSD strategy. And these are just some examples of some attributes that we'll be looking at in terms of the DCE. hoping then that after that, we'll be able to test these various DSD models with hypertension, one, assessing the perspectives of health providers and policymakers, and then two, develop the implementation strategies for its delivery, and then finally to test the effectiveness of these. So I will end there and probably give more time to discussion, but I want to thank many people, my mentors, the teams on the ground who worked with IRTP, where I did my work, and obviously our global cardiovascular health program, and Chris, who continues to support me in this journey. So thank you so much, and Kerry as well, who's been my long-term mentor. Thank you. This is Nairobi for those who have not been to Nairobi.